made for clarification of what is ABUL Cranial Shift and to explain the related article about it. So the name of the article was, if you look this way, you'll see it, Cranial Shift in Adolescent Idiopathic Scoliosis. And it has just, I've just seen this tweet by Dr. Davis on beware, there may be some anatomical variations in the surgery field. So this is just after our article, so I liked it. And I will start with a presentation of a case. This looks a fairly normal scoliosis patient. Looks normal to the normal surgeon eyes. And these are the clinical images. And when we look in further detail, we see that there are some changes in the thoracic and lumbar part. So we see that very tiny T12 costas on both sides, and L5 has a marked transverse process on the right side, as you can see on the images. So, and in addition to that, C7 vertebra has also marked transverse processes, even episoid articulation of cervical costa if you look close enough. And you can also see in other X-ray images and MRI here that the patient has this, and this problems together. And Castelvi, as you may know, described first the lumbosacral transitional anomalies of sacralization, and this patient has this 1A pathology. And in another case, if you can see that C7 vertebral transverse process is very prominent, and T12 costs are bilaterally rudimentary, and the L5S1 is totally sacralized here. So normally we have 24 presacral mobile vertebra. This is the big point in this presentation, and it goes to directly to 23 when you have this cranial shift. What we call is the fusion is going one level upward intrauterинely. So let's start from the what is normal for the vertebral column. As you may know that the vertebral column consists of 33 vertebrae. We have 7 cervical vertebrae, which is a constant number actually for mammals, and 12 thoracic, 5 lumbar, 5 sacral, and 3 to 5 normally 4 coccygeal vertebrae. And when we say what is normal, we have 24 mobile vertebrae, as I just stated, and sacrum and coccyx. And if you include the pelvis also, it's also the main vertebra of the spinal column, you know. And we have 23 movable discs. I'll say it again, we have 24 mobile vertebrae in normal spinal column, and it is very important for surgeons when making fusion selection and decision making. There are only 2 exceptions to this rule, which is for mammals. We have 7 cervical vertebrae. It doesn't change, it's proven, but the thoracic and lumbar vertebrae may change in numbers. And this sweet creature has more other than 7 vertebrae. And what we call is transitional vertebra is it is a change between the transition from the cervicothoracic, thoracolumbar, and lumbosacral regions. And when we say that this transitional vertebra, it may even be going upward and downward changes. When thoracolumbar transitional vertebra, it is most of the time missing of the 12th costas, or we may see just a rudimentary costa on either side or bilaterally happening. Less of the time we may see costal perturbation on L1 vertebra. And when we say lumbosacral transitional vertebra in next slide, we see that L5 is fused to the S1. It means that normally fused sacral vertebrae goes one level upward, going cranially, and it is the sacralization what we know as, or L5S1 transitional vertebra, we can say. And less of the time we can see lumbarization. It means that S1 and S2 may have a disc between them, movable discs, but most of the time we see it as sacralization. So these are the broad names. It may either be cranial or caudal changes on either transitional border. So actually we see both of this, thoracolumbar and lumbosacral transitional vertebrae, together in the same patient. This is all about our manuscript article. So why didn't we know this before? Actually, we just have this whole spine images for maybe the rest of 20 to 30 years. Before that, we just had this cervical X-ray, thoracic X-ray, or lumbar X-ray separated, or even we had MRI on only the lumbar part. We know that it doesn't change the 7 number of cervical vertebrae. So when we look at this, we can say that there's a cervical vertebra here. And if we have just this thoracic X-ray, we can say that 12 or 11 pair of costa the patient has. But when we have the lumbar X-ray, we cannot assume what it is. Is it normal? Is it sacralization or lumbarization? Because we cannot count the upper parts of the spinal column. That was the confusing thing, I guess. And after that, we this X-rays for 2 or 3 decades. This shows the spinal column as a whole. Actually, we have more than this. We have also EOS X-rays showing the whole body in double slot technology, topographic X-rays, and we can clearly see that how many vertebrae we have. And when we're coming to the explanation of cranial shift, as we say that anatomical variations in the spine at the transitional borders may go towards the skull as cranial shift or away from the skull, and it's called caudal shift. And when we say cranial shift, I will just repeat the things again and again in the rest of the slides. We may see C7 cervical rib or pronounced transverse processes as a cranial shift component, or at the thoracolumbar junction, we may see a transitional vertebral T12. We may see some costal changes with the naked eye on the X-ray as clinicians, and we may also see in the lumbar sacral junction, when we say cranial shift, we see sacralization on the L5 and S1 transitional vertebra. And we may also see sacrococcygeal fusion, but it is actually not that clinically visible to the naked eye. And when we say cranial shift, when we look at the X-ray, it is easy to see the cervicothoracic region, thoracolumbar region, and lumbosacral regions. But as clinicians, and for the surgery, for adolescent idiopathic scoliosis cases, it is important to, for us, the thoracal and lumbar portions. So for motion segment preservation and level selection, it is important to see the thoracolumbar and lumbosacral regions together. And in this study, we called this phenomenon, I mean, absence or shortness of T12 costa as thoracolumbar transitional vertebra and sacralization of L5 to S1 vertebra with together with scoliosis, we called it ABUL cranial shift phenomenon. And we sought for the incidence of ABUL cranial shift in 187 surgically treated adolescent idiopathic cases. These are the general material and methods which we downloaded for the study. So what we did was we just used the normally known traditional spinal enumeration method for the radiographs. What was that? All vertebral levels based on the assumption that there are 24 presacral mobile vertebra. Looking at the AP and lateral images on the spinal column, we name it the relative to 7 cervical, 12 thoracic, and 5 lumbar vertebra. I mean, if the patient has 12 pairs of costa, only 12 pairs of costa, we said that the 12th is without costa. It was the 19th vertebra. And we started to count down from the C2 vertebra because it's easily visible on the X-rays, and we count down until to the 12th vertebra, and we named the 12th one as L1, so because the normal anatomy is like so, and the 24th vertebra as L5. And we say that if the rib articulation in the 7th vertebra or the pronounced transverse process vertebra exists, we stated that. And the absence of ribs in the 12th, 19th vertebra, what we call as T12 in normal anatomy, according to the relative to the normal anatomy, and the marked smaller size of the 12th costas. And as a third measurement, we stated that the abnormal fusion sacralization between 24th and L5 between 25th and S1 vertebra as sacralization. We all reported, collected this data. What we saw very shocking in the study cohort, ABUL cranial shift was observed in 1 of every 5 patients. In other words, 19% of the patients we saw ABUL cranial shift in adults of idiopathic scoliosis cases. These are the other related data which we collected. So the most of the time in Castelli classification, we saw a type 3B and type 2B sacralizations. And as a result, what we found was in IS cases, anatomical variations in the spine can be seen and lead to wrong level surgery because we need to, as I said in the Twitter post of Dr. David Skaggs, it may only be 11 pair of ribs, or the 12th vertebra may have very, very tiny ribs. So we may it may mislead us to a wrong level, as we may think that it is T12, but in fact it may be T11 vertebra. So the wrong level surgery is very important topic of this manuscript. And existence of this sacralization together with the shortness or absence of the 12 ribs has not been discussed in AIS cases before, but it had a place in paleopathology and for the normal anatomy nearly a century ago, because they had chance to take this spinal column as a whole from the buried places, and they can see that there's a cranial shift here in the lumbosacral junction, thoracolumbar junction, and the cervicothoracic junction. And the of ABUL cranial shift is important in preoperative patient education also, and the process of informed consent state. Normal number of 24 presacral mobile vertebra drops to 23 for ABUL cranial shift cases. So this leads to a necessity to discuss the distal fusion level in detail with patients and their caregivers. It is very important, because we may choose the lower instrumented level in L3 for normal anatomy, but if the patient has an ABUL cranial shift, we may say to the patient and the family that it would be proper to go 1 level up, maybe with a slight lumbar curve, acceptable lumbar curve, but it will preserve more motion, so it's very important. And the presence of vertebral column variations should only be addressed by radiological or anatomical holistic evaluation of the entire vertebral column. So we need to see the whole spine to decide what to do in next step. And accepting the assumption of C7, T12, and L5 as an immutable rule, the determination of relative deviations from it in the evaluation of anatomical variations in everyday practice, it is recommended for clinicians to provide ease of interpretation. In the presence of thoracolumbar pathologies, transitional pathologies, I mean TLTF, in AS cases, the presence of accompanying lumbosacral transitional vertebra is likely. This is a credit. Actually, the name is not ABUL cranial shift. I wanted it to be the Alanai cranial shift, but Dr. Alanai said that you found this, so it should be ABUL cranial shift. So I actually thank him. He's my big mentor, my big boss. Thank you very much. If you have any questions, or we may think on validation around the world, because I think it's a big issue, and I'm so excited about this manuscript, this idea. We need to discuss it more in maybe normal anatomy, and there are a lot of combinations to search for it. Thank you very much for listening.